I'm Chris Morris, Principal Analyst for South Central and West CSU. One of my primary areas is around risk stratification, but of course falling out of that is the kind of stuff that you can do with using the data that you get for risk stratification that supports broader population analytics, and that's really what I'm going to be talking about for the next 15 minutes. Okay, so I'm going to talk very briefly about how does population-based analysis differ from the sort of analysis that you're probably more familiar with. Talk a little bit about the kinds of value that we think we can add from doing more of that type of work, and then just describe some of the current uses, some of the ways that we're already deriving value from that data, and then just very briefly touch on some of the perhaps future potential for more that we could do in future with these kinds of approaches. So how does population-based analysis differ from more conventional type of analysis? Well, you'd probably all be familiar with data sets that look a little bit like the sort of slightly fictitious one on the left here. And that's a conventional data set might include details like patient-level details like identifiers, age, gender, those sorts of demographic pieces of information that tell us things about the patient. But actually the focus of those sorts of data sets tends to be primarily around aggregated activity and cost, episodes rather than individual patients, and we tend to split the summary of that sort of data by features like point of delivery, specialty, HRG code, ICD-10 diagnosis, those sorts of features. And that's quite useful for lots of things, probably, I don't know, 50-70% of the stuff that commissioners are interested in. But it only ever gives us a partial explanation of the population drivers for any particular activity or cost. It tells us very little about any particular patient or patient cohort's overall experience of the healthcare system. It only tells us about the clinical features that were salient in a particular episode and not the patient's broader level of complexity or care needs. And it's also not a joined up view of healthcare. And as Sarah said, we're increasingly starting to move to try to move towards a much more integrated understanding of those sorts of needs. In fact, with this standard approach, and sort of visualised it here, we've put the commissioner in the middle, and we're sort of firing all these bits of information into that centre. For me, that's not the most helpful approach. As I say, it works for certain things, but it doesn't allow the commission to formulate a sort of integrated understanding of the system. It's forcing quite a lot of very hard work to be done in interpretation. And finally, and this is very much a personal view, I don't think this kind of approach necessarily tends to engage with clinicians, which is obviously hugely important. So with population-based analysis, we seek to cover the entire population. It puts the patient at the centre of the picture, and we seek to build meaningful patient cohorts or segments, as we might describe them, based on demographic and clinical features. So the starting point is this here. We start out trying to cover the entire population, understand the age profile, the conditions, multimorbidity, the total level of multimorbidity, or the specific conditions that make up that multimorbidity. We might want to understand other demographic features like location, and we might derive things like Casemix groups or segments from that information. And then we seek to use that information as a lens through which we understand everything on the right-hand side here. So that sort of forms a very different approach. Rather than starting with the data and then trying to understand this, we start with this, the population, and try to understand activity and cost in that context. So it's quite conceptually, it's quite a different approach. And I think this approach also has the ability to better engage clinicians whilst still delivering all of that key information that commissioners need. So the value that approaching data in that way adds is that it enables us to analyse for a whole population, not just those people who happen to turn up in a certain service. It facilitates our understanding based on the full population picture of disease, age, multimorbidity, whatever other demographic features we're interested in, not just what happened to be coded in certain encounters. It allows us to describe utilisation and cost in much broader, more meaningful terms in terms of the system as a whole. And it's also conducive to unpicking the sometimes highly complex interrelationships between the different types of activity based on the population cohorts or levels of multimorbidity or specific conditions that drive them. And that's really key for work like transformation work, as I'm sure you'll all be aware. It also forms a bridge between the clinical viewpoint, I'm generalising hugely here, but the clinical viewpoint is broadly about the patient, and the commissioning viewpoint, which is broadly about utilisation and cost, so it forms a bridge between those. It's scalable, so any data set that we can get NHS number with can be added, so social care, I think if if I'm right in remembering. I think Symphony, which we'll be hearing about later on, has incorporated some elements of social care data, and other areas in the country are starting to look at that. But also non-standard NHS data sets. So I mean, sort of historically, data sets like mental health, community data, those sorts of things, which they tend to be a little bit more non-standard than SUS standard commissioning data sets. You can incorporate that information. It's scalable, provided you can get an NHS number for the linkage. And it also, of course, supports future models of integrated care, so things like Better Care Fund, Vanguard, again, you'll be hearing about that later on, but more generic types of integrated approaches, like joint health and social care budgets. So the current uses, which I won't dwell too long on, I think you're all familiar with sort of predictive risk data sets that use features like these ones here. The first column that I've highlighted over there is the risk of emergency hospitalisation, and you might use the other elements that are in that data. So this is a resource utilisation band, is a measure of sort of total complexity, or you might use specific conditions. So this one here, asthma. But there are also opportunities to use, even within the tools that we already have, to better use the data that already exists within those. So some of the features, I'm not sure how well you'll be able to see this at the back, but some of the features on the far left-hand side there include risk, or rather predicted total cost range. So for any particular individual, we get a predicted cost for that person. And on the right-hand side here, we've got a number of different ways of looking at risk of hospitalisation. So you can see there that we've got the risk of an extended hospitalisation, and we could combine that perhaps with the risk of an emergency hospitalisation. So that might be your sort of delayed transfers of care cohort taken care of, or a different way that you could use that risk stratification data to current uses. So another way that we can start to use this data is to map disease prevalence. So with existing data sources like QOF data, that data is only currently available at practice level. So practices are not, strictly speaking, geographically distinct. So it's actually quite difficult to throw that kind of information on a map. So for the first time with the data that you can get from population type analysis, you can throw together, and this is a very simplified map, we've got geospatial information experts who can do a much better job, but you sort of get the idea that for the first time we can start to really describe disease prevalence geographically. Population segmentation, again, it's sort of the core of what I think I want to spend time talking about this morning. There's a key principle with population segmentation, and that's the idea of mutually exclusive segments. And that's so that when you're understanding features like utilisation and cost in the context of those segments, you're not double counting. And by that I mean, if you were to split your population by single diseases, people can have anything from 0 to potentially hundreds of individual conditions or codes for those conditions. So if you were to try to disaggregate cost on the basis of conditions, you'd be double counting. Some people have CHD and COPD, so you can't sort of disaggregate that cost. So mutually exclusive segments is quite a key component. That enables us to aggregate hugely diverse populations into segments that are likely to have similar healthcare resource needs, and that also helps us to describe and compare populations and also identify specific segments to form the basis of commissioning plans. And you'll all be familiar with some variant probably of the idea of complex elderly, frail elderly. I'm not aware of a healthcare system that's not currently interested in that particular cohort. So this is an example of a way that we've approached segmentation to date, and I think you'll sort of see a couple of examples of it done slightly differently later on this morning. But we've taken 5-year age band and put it into very generic age groups. Obviously that feature is highly flexible depending on your particular local interest. You might have certain specific age bands or groups that you're interested in. And we've taken a measure of multimorbidity based on the QOF long-term conditions, disease registers. That's both for familiarity but also likelihood of the coding of those conditions being consistent. And what that gives us is this sort of inverse pyramid where we've got a relatively high percentage of the population will have none of those conditions, and then decreasing numbers as we move through levels of multimorbidity. And I think you'll see an example of a slightly different definition of multimorbidity and a slightly different distribution, but the shape of it will be the same. Fewer people with more people with fewer, lower level of multimorbidity, and smaller numbers as you move to increasing levels of multimorbidity. And what this approach gives us is this, in this cross-tabulation, these sort of 6 segment tiers, if you like, based on level of multimorbidity. And sort of in the first column here, in the 0 to 19-year-olds, you can see they constitute about 23% of the population in total, and almost all of them, almost 21% of that 23%, has no QOF conditions. So there's very little multimorbidity there. I should just note actually that where we've got NA, there were so few young children and younger people with more than 2 QOF conditions that we've just collapsed all of that group together. Then we move to adults of working age, and you can see they constitute about 3/5 of the population, and about 45% or 3/4 of that total have no conditions. But already we're starting to see that about 1/4 of those people have at least one condition, and in some cases more than one. And then as we move through the older age bands, as you might expect, that relationship changes slightly. So almost 12% of the population are aged 65 to 79, but only about 4% of that 12%, or 1 in 3, have no long-term conditions, no chronic conditions. And the way that you can start to use that information is to, again, this is just a data table that's been enhanced with some coloured bars. There's 2 ways you can interpret this table. The important point here is that we've got the groups based on 0 LTCs plus age bands at the top here, and the groups based on many LTCs at the high levels of multimorbidity down here, and then age sort of follows in those groupings. The first way that you can draw a comparison is to look at the difference between the percentage of people in the population in that particular cohort compared to the percentage of a particular activity or cost that they consume. So we can see that children and younger people with no QOF LTCs, it's about 20% of the population, and they consume a little over 20% of A&E attendances. So the sort of population rate is fairly well matched to the number of people in that group. But at the other end of the scale, we've got in the group with 5 or more QOF LTCs who are aged 80 plus, they're about 0.5% of the population, but they make up almost 2% of the A&E attendances. The other way that you can look at this table is to follow the rate per thousand, which is sort of the same information that you're getting from the difference between those 2 bars. But as you move from least multimorbid, the rate per thousand, to 300, 200, down to high levels of multimorbidity, the rate per thousand is in excess of 1,500. It's almost 2 A&E attendances per person in some of these cohorts. And exactly the same thing is true of emergency admissions. In fact, that's probably a more distinct curve. The oddity in the middle of the graph here is I mentioned earlier on that we collapsed all of the children and younger people with more than 2 QOF LTCs into one group because they were such tiny numbers. But what it does mean is that we've included in that group, it's a relatively small number of people, but they will be a sort of select case of very highly complex paediatrics, and that's what gives us that sort of oddity in the middle of the graph there. And it's exactly the same pattern in planned care. That's elective admissions in that first column. So again, very, very distinct, low rates through to high rates. And again, in outpatient appointments, low rates through to high rates. And it's exactly the same again in primary care. In fact, the pattern is probably even more distinct here. It's, as an analyst, we all like sort of nice, neat patterns, and it's almost a perfect curve. In fact, moving from least multimorbid to most multimorbid. So it allows us to start to quantify, what we would expect to see this naturally, intuitively. But for the first time, it allows us to quantify that. And as we'll see when we talk about Casemix adjustment, it allows us to quantify it in a way that we can then use that information to understand variation. And lastly on segmentation, this is just a slightly different method. So the previous method is all about grouping people based on the number of conditions they have. And this approach is something we've been trialling with a particular CCG, and clinicians in particular are very keen on this, because what we've done here is group people on the basis of a statistical approach, but grouping people on the basis of the sort of the complex of specific conditions that they have. So these are mutually exclusive groups, but we're still able to describe them on the basis of clinical features. So you probably can't see this too well at the back, but we've got cancer clusters up here. We've got people with cancer only, and this little graphic on the end here is just a very high level age distribution. So you can see that people with cancer only, the peak of that distribution is in people in their 60s. But people with cancer with hypertension only, those two things in isolation, the age distribution is slightly different still. And I haven't shown it on here, but actually when you start to look at cost and the differences in cost and utilisation between these different groups, as well as the age distribution being different, the cost and utilisation is different as well, which tells us that these groups are a useful construct for understanding variation in those sorts of things. So similar patterns, again, cancer, we've got similar things with, in the cardiovascular clusters, people with CHD only follows a certain age distribution. It might be a slightly different age distribution if you've got CHD and hypertension, or CHD with some other combination, and similar patterns are true with obesity on its own, obesity with other things, diabetes on its own. So those sorts of combinations. I think what appeals to clinicians in particular about this is they can look at those groups and see immediately what is meant by those groups, which is something that's perhaps not so evident when you're talking about, you know, one QOF condition, which could be any one of those QOF conditions. It's not a clinically distinct group. It's simply based on a number that describes the number of conditions. So moving on to case mix adjustment, the idea is that we can describe differences in case mix between populations, so localities or practices, and then use that information to help explain and better understand variation. So this is a very busy graph, and you can probably ignore everything that's happening above a line that I'm drawing sort of with my finger here, simply because the distributions are based on very, very small numbers. But the important feature of this graph, we've got multimorbidity running across the top, 0 conditions over there to 5 or more here, and age bands running from 0 to 4 up to 95 plus here. And the bars in the middle are describing, it's a little bit like looking at the distribution from above. The red line in the middle is the median cost, and in some of these cases the median cost is so far over to the left that it's 0, which is why we don't have blue bars here. But the important feature of this graph is that the cost doesn't change as you move through the age bands at the same level of multimorbidity. Very little difference. If you've got 0 QOF LTCs, there's very little difference in the distribution, whether you're a child or a younger person through to someone who's much older. But the distribution does change. It's almost a step change as you move across level of multimorbidity. So another way of saying that is if you're 50 years old and have 5 or more QOF conditions, you're much more likely to be a high-cost, high-using patient than somebody twice your age that has no QOF conditions. And it's exactly the same pattern in primary care. This is primary care activity rather than cost. There's a little bit more evidence that as you move to older age at 0 multimorbidities, there's a little bit of a shift in cost, activity. But again, the much more distinct pattern is as you move across levels of multimorbidity to the point where you see that same pattern there for those with 5 or more QOF conditions. So the reason it's important to be able to know that and to quantify it is because practices, and you'll be familiar with this in your practice as well, practices have always said to us that my population is different and standard analysis hasn't taken account of that. That's a message that we hear very clearly almost everywhere we look at data. So again, I've taken this data table. This is looking at QOF multimorbidity across 10 practices. It's real data. And what we can see is that for practice C, comparing practice C, which is at the highest level of highest percentage of people with 3 QOF conditions, compared to practice J, which is the lowest percent, there's about a 3-fold variation. So assuming those practices are the same size, this practice is dealing with 3 times the volume of people with 3 QOF conditions. And what we've seen from the previous data is that because of that, we should expect this practice to have much higher cost. That pattern's also pretty much identical for those with 4 conditions. The variation is about 3-fold. And here again, it's also about 3-fold. So if I was a betting man, as an analyst, I'm actually not, but if I was to make a guess as to the cost, the difference between these practices, I would bet a fair amount of money that this practice is generating more utilisation and cost. And the difference that can make to our understanding of activity and cost is very significant. In that first example there, we're looking at a standard way of approaching analysis, and again, you'll all be familiar with looking at data in this particular way. And by that first method, we'd probably point out practice 2, 4, 6 and 7 and say you're higher than the average, that's bad, please somehow stop having so many emergency admissions. Practice 8 and 9, who are lower than the PCT or CCG average, we'd say well done, keep doing what you're doing. The other practices, depending on this year's flavour of emergency admission reduction, we might not say anything at all to them. But when we bring case mix into the equation, it paints a very different picture. Two of the practices that we were interested in before because they appeared to be high are no higher than we would expect given the case mix. Two of the practices that we thought were high are actually higher, even higher still than we would expect given their case mix. The two that we thought were doing really well and having low emergency admissions, one of them is pretty much exactly where you'd expect them to be. There's maybe an argument to say that practice should be commended because they've probably been under very little pressure to have fewer emergency admissions and yet have maintained that low level. And practice 9 here, although it has a low level in comparison to the CCG average, actually has a higher emergency admission rate than we would expect, given the case mix that makes up its population. And some of the other practices we weren't interested in at all before. The first one has a lower rate than we would expect, given its case mix. So we should probably try to understand what that practice does so well that keeps emergency admissions down. And the practice on the end here, although it's no different to the average, actually has something like twice as many emergency admissions as we would expect. I think sort of data quality and robustness is maybe outside of the scope of this morning's meeting, and variation of that kind we would certainly want to investigate it. But I think you sort of see the point about the different picture that the different approach can paint. And then this is just an example of having used the clinical clusters. So that was the groupings that I talked about, which were based on specific combinations of particular conditions. And again, I think this was emergency admissions as well. And that the important point here is that there is variation in the actual rate of emergency admissions, and we would expect some of that variation. But the ability to have a specific benchmark for each practice based on the case mix it has is a very, very powerful way of starting to understand variation. So just very briefly talking about the future potential, I mean, I can see that this sort of approach in future getting to a point where we have what I would describe as total vertical and horizontal data integration. So a kind of a super data set where we could, in theory, have every person in the population, every activity, every cost, and ways of breaking that down and understanding it. And I think we should start to then seek to utilise that kind of information as really as almost a cornerstone of business as usual analytics for commissioning. And I think John's going to talk a little bit about the way that Symphony has already started to move informatics in that direction. And also I think in future we can start to think much more smartly and align services and contracts much better with populations and their specific needs, not just with providers, activity, or the way we've always done it.